welcome everyone to the fifth OMOP Special Interest Group meeting. I'm really delighted to be with all of you and chairing this session today. We are missing our co-chair, Geoff Hall, who is feeling unwell, and I really want to send him my best wishes for a very speedy and full recovery. We do have a total of 4 speakers today with very interesting talks and very interesting content. So I'm not going to dwell too much on my welcome and introductions, just to give you a very quick update on a few things. First, everyone, please pencil in your diaries. 6th of May, 1 p.m. is when we're going to have our 6th OMOP Special Interest Group meeting. So if you can please pencil that in. The Alliance team will be sending out emails for registration near that date. But if you can please book that date in your calendars, that would be fantastic. Second announcement, we now have a very well-populated website with information on the ODC UK 2024 meeting that was very graciously hosted by HDRA UK in London, and hopefully you will have some fun reviewing that. I wonder, Alex or Wai, if you can please copy in the chat the link to that. Third, the 2025 edition of the ODC UK meeting is now being organized, and we do have a date for it. Please, again, pencil in your calendars the 26th of September of this current year, 2025. So pencil that in and book that date in your diaries for our 2025 ODC UK meeting. You will hear more news near that date. And then finally, to mention that there is a recording of our previous 4th OMOP Special Interest Group meeting available in YouTube. Alex has, I think, already posted in the chat the link to that. If anybody has an interest to revisit that or see it, please look at that. Other than that, just to welcome you to another year, trying to share our experiences and our knowledge on the use of OMOP to facilitate federated analytics nationally across the UK and where possible internationally with other partners. We have 4 speakers, as I mentioned, who are going to be talking about the real-world evidence network. We'll hear an update from Ed Bunn, who I saw already in the audience. We have Rachel CP from Cambridge, who's going to be speaking about the standardization of multi-agency data to OMOP. Then Esmond Merwin is going to speak about OMOP mapping tools and the Carrot Mapper. And then finally, we will have Queen Ashcroft from Lancashire speaking about integrating OMOP data into the monitoring, the daily monitoring of sepsis patients. And hopefully we will try to leave 10 to 15 minutes for Q&A at the end. So please feel free to post your questions in the chat if you want to have them there. Or to raise your hand if you want to ask any questions. We will take all the questions at the end of the session, but please do not unmute yourselves unless you're speaking, because there's a lot of people in the call. I think there's like over 50 people right now. Okay, with that, I think I've already gained some 5 minutes that maybe we can use for Q&A at the end. And I don't know, Ed, if you're ready with your presentation to kick off the meeting with the update on the real-world evidence network.
Hi, Danny. Sorry, I'm just having to restart my computer. Might just take 1 or 2 minutes.
That's okay. Go for it. Can I confirm that we have Rachel, Esmond, and Queen already in the call?
Yes, hello.
I can see Esmond. I can see Rachel.
Yeah, hi.
Haven't seen Queen. Hopefully she's here as well. Thank you. Thanks, Alex, for copying the agenda. Rachel, would you mind?
Yeah, that's
being
fine.
the first one to present? Is that okay? While we wait for Ed to reboot his computer, is that okay?
Absolutely.
Fantastic.
All right, I'll do a quick screen share. Can you see my slides all right?
Yeah, not in presentation mode yet,
Yeah.
but I can see them.
There we go.
There
Okay.
you go.
So thanks so much for having me. I'll be speaking to you about standardization of multi-agency data, and specifically, I'll be focusing on social care data for this talk. So I work with building the UKHDRA data resource from the Timely team out of Cambridge, led by Dr. Anna Moore. And we are focused on mental health data and children's mental health in particular. And the database is built using data coming from multiple geographic sites. And it is intended that each site would contain data coming from more than one agency. So primarily those would be healthcare agencies, but it could also include social care, education data, and our aspiration is also to include genomics data. The reasoning for this is because children are often spending a lot of time in the education system. They may spend a lot of time in the social care system, and for a condition with kind of multiple factors that feed into it, we found that we really want to have a very comprehensive picture of children in order to understand mental health outcomes. So right now we're focused on data coming out of Cambridge. That's where we're based. So that's where our pilot data has come from. So for UKHDRA, as I mentioned, the input data could come from a number of sources, and the intended use could be for research. It could be for service improvement in any of the agencies that are sharing the data. It could be to decide resource use. So it has a number of uses. But obviously, if we want to use all of this data together, it needs to be standardized. And OMOP, which we've chosen as our standardization, is intended for use with health data. So we found ourselves asking if this non-health data, so data that come from social care or education, could it actually fit into the OMOP CDM? And so I'll be going through what's the typical structure of social care data, what are the variables that we're finding, and how do we see that they could fit into the OMOP CDM, and can it map to the OMOP vocabulary? So this looks very overwhelming at first, but each of the boxes is representing the tables that are found within our social care data. So it's a relatively small data set coming from Cambridgeshire County Council, and it contains 14 tables, and there's nearly 200 variables across those tables. The tables have been kind of grouped into boxes. So you'll see the first one here lists 4 tables: person, language, address, disability. And I've laid them along a timeline, but social care data are very complex in that, time is maybe not as linear as it's laid out here. So I'll talk you through this in a little more detail. So I've tried to lay it out as being in a person-centric model so that we could find how it might best fit into OMOP. And so we find that there's a lot of data related to the child or the client, just about them, and then they have their initial referral. The boxes that are in red, so assessments and contacts, they'll typically have many of those. There'll be lots of contacts, lots of assessments. So these can be thought of as kind of different encounters with the social care system. They may or may not have a strategy discussion. And then the categories that are over on the right-hand side, so early help, child in need, protected child, and looked after children, those are sort of levels of care or tiers of care. So early help is like a very low-level intervention. Child in need is like the next step up. And then protected child and looked after child are sort of the more serious levels of care, with looked after child being like having a legal designation placed upon it, and it may be that social care has taken responsibility for the child. So there's bits of data that would be collected depending on which category a child falls into. And then you can be bumped up and down out of these tiers, and you might circle back and have another assessment. So, you know, a lot of these processes can be iterative. So we roughly can fit things into a person-centric model. So that gave us hope for the use of OMOP. So a lot of the tables from social care fit really easily into OMOP tables. So the social care tables about the child, so the person table, language, address, disability, those all really fit into either the person table, location for address information, disability information is mostly fitting into conditions, and then other information, so like language and sort of the more detailed demographic information all fits nicely as observations. When we think about those interactions, so I mentioned that we have these different categories of children. So are they a looked after child? Are they a protected child? Are they getting assessed? Are they having contacts? Those are all different types of interactions, and they all fit really nicely into either a procedure, an observation, or some type of measurement. We can think of the social care staff and teams as being a provider, so they just become a provider in the OMOP table. And then depending on how much information we have about where the social care staff are working, we're considering the addition of care sites as the different departments of social care. So that's something that we're kind of discussing among our team, if we want that information or not. So the problem we started to run into is we found that there's a lot of data, or a notable amount of the data is not necessarily what we would call person-centric. So in social care, there are a lot of interactions that are occurring that don't involve the person. So it's if the social team is having an internal discussion where they're trying to make a decision about what to do for the child, or they're interacting with the legal system, police, the school. And so those are occurring between different agencies, and it's not necessarily that the child was involved in that interaction at all. And so we found ourselves kind of wondering, well, this is important information, decisions are being made about the child's care, but it doesn't necessarily fit in a very, we weren't sure how we would fit this into the OMOP model, given that it is a person-centric model. So I'm going to return to these specific circumstances at the end of the talk, so you'll know where we ended up on it. But I want to give you a little more detail about the mapping of the variables. So our first step in OMOP, and if you were able to attend the talk in September for the Odyssey UK, you'll have seen a bit of this part of the slides. So we're trying to make decisions about which variables do we want to keep. That's sort of our first ETL decision. So we tried to really streamline this process and say, do we understand what the variable is? And then clearing out those variables that we didn't feel that we needed to conserve, either because it was redundant or it was an artifact of processing. Those are the types of things we don't really want to keep in our OMOP mapping. And then we were using the caret mapper as a to drive a lot of our mapping. So because of that, the way that software functions, things like dates and primary IDs don't need to be explicitly mapped, but they are conserved in the process. And then everything else is, sorry, what?
I think someone probably unmuted.
Okay.
Rachel. Go ahead.
Yeah. And then everything else is sort of the part that takes all of our effort, right? So all of the kind of the manual mapping that occurs. And so we tried to break these into categories that were developed by a group out of Austria. And it was basically this 3-tier system of it's type 1, then it's directly mappable. The exact concept exists in OMOP. S2 means maybe it's not exactly the same, but the sentiment or the meaning is conserved. And then S3 means it doesn't exist in OMOP in any form. And then we also found that during this part that we realized, okay, maybe we actually don't understand the variable. So it got put into the unclear category. And you see, we kind of have this decision tree to help us move through the variables in the most efficient way possible. To give you a couple examples of those categorizations, so a type S1 is at the top here. So this is a case where a child in protection, they give you the reason that the child is protected, and it might be for emotional abuse. And so that concept already exists in OMOP. And so we feel that that's very well represented. For S2, this is a little more subjective. So one of the second line here is one of the outcomes of a discussion could be social care decides that they need to take legal action. And so the concept of legal proceedings having occurred also exists in OMOP. Another possible outcome from an assessment could be that they decide that the family needs some short break care or short break support. We felt that this was similar to when a patient gets respite care. So we felt that that was a good representation of that concept that exists in OMOP. But there were a number of variables from social care that we weren't able to find a good way to represent them in OMOP. And so one of the example of that is the reason that a social care referral comes to an end. And we couldn't find something that was just quite capturing that. So that one is been left up in the air for us for now. So if we look overall at those nearly 200 variables that we had, we found that there were a lot of redundancies. So there were just a lot of variables that we didn't need to bother trying to keep. And then a number that we were going to keep, but we didn't need to spend effort on. And then of those that remained, 30% of the total were mappable, but most of those we were able to map directly. So overall, of the ones that we wanted to keep, most of them fit into the OMOP vocabulary. For the ones that I've mentioned here that we found, okay, well, maybe they're a little unclear, that means that we found during the mapping that we needed more context or more information to understand the variable and choose the appropriate mapping. And so for that, we organized an expert panel. So the purpose of this was basically to say, for the ones where we felt that we had an appropriate mapping, to get some confirmation of that. So did they feel that we had represented these concepts correctly? And then there were a number where we had really specific questions to understand the variable better and to make sure that we could choose the best representation. So in order to do this, we found experts from academia and government to come to an in-person workshop. And we were able to get 3 participants and basically led a series of discussions on the variables that I mentioned before, showing them examples, and then asking those clarifying questions in order to better understand some of these details. The participants were great. It was like they were excited to be involved in it. We did offer lunch and we covered travel. And so this was a really good way for us to get this detailed information, given that social care my background is more in health research. I've done a tiny bit of social care work in the US, so it really helped to have these experts to get clarification on the data here. And so this also helped us to understand what to do with those interactions that I mentioned at the beginning of the talk, where it's not quite person-centric information. And so after discussing with the experts, they clarified that, they wanted to know if there were these interactions between social care and an external party, so the police, a teacher, a concerned citizen. It was important to know who that person was and to maintain that information. And then also, when the discussions or contacts had some kind of outcome, they said that it was safe to treat those as a real outcome. It wasn't just we discussed this and then we think that this will happen. They said that if an outcome was recorded, that was definitely something that happened after the contact. So for contacts, here's what we ended up doing. So in some cases, the contact is actually between the child and social care or the family and social care. And so for those, we felt that it was safe to store those as a discussion type encounter between, which is a type of procedure with social care team as the provider, and so that being recorded to the person record in OMOP. For the contacts where it's just social care with some other entity, we did find that there is a type of procedure to represent liaising with another source. And there are a number of contacts or a number of concepts that cover the type of interactions that we are recording here. So for these contacts, they've been stored as a liaising with, and then fill in whoever the relevant party is as a type of procedure in OMOP. And then the outcomes get stored as types of observations. For the strategy discussions, where those are more internal to social care, we found that social services care planning is a type of procedure, and that could be recorded as well under that concept. And again, with outcomes being stored as observations. And so this has all been our first OMOP version of it. And so this is something, now that we've mapped everything, we will be taking it back to our experts to discuss and confirm that we have done the best representation. As we all know, OMOPing is an iterative process, so I'm happy to have shown and shared with you all what we found in undertaking this. Overall, if this is something that you would like to try to do, we found that there's a lot of redundancies, so taking the time to examine the tables and understand everything to reduce your mapping effort is worth it to do at the beginning. We found that most of the variables are well represented in OMOP, but then you need to kind of think carefully because there are a few types of interactions in social care that are not, don't perfectly translate to a person-centric model, but you do need to, if you put some thought into it, it is possible to get them in there. All right, thank you so much.
Thank you so much, Rachel. That was a fantastic and very comprehensive presentation. If people can please start writing questions in the chat. If there's no burning question, we can probably continue with the other presenters. You can stay until the end, right, Rachel? Yeah, fantastic.
Absolutely.
Great. Thank you so much. Ed, are you ready? And is your computer ready as well now? For your
let's give it a go, hopefully. Let me try. So hopefully you can see my slides.
Yeah, very good.
Okay, perfect. Great. Well, thanks for having me. I'm going to do a quick update on progress in the HDR UK Real World Evidence Network. So just to start with a bit of background. So last year, there was a call for funding from HDR UK to set up a Real World Evidence Network Coordination Centre. This was a one-year pilot. And so it was funding for the coordination centre, and then creating a data network to go along with it. So here in Oxford, we were fortunate enough to be awarded it, and we have 3 different work packages that are operating. So we have the first one being the data network. So in this work package, we're focusing on onboarding data partners to the network and making sure that they're ready to perform network studies. In the second, we have pilot studies. So here we're going to do a couple of studies to demonstrate the value of the network, and identify any gaps in the data, or also the tooling that might limit what studies we can do at the moment. And then the third work package was all around sustainability, and it's about overseeing the pilot phase and also identifying how we might be able to secure the sustainability of the network beyond this first year. So just to go through the timeline of the project, so it started in June 2024 and it will finish in June 2025. In October, there was a data partner selection, so there was an open call for data partners, and then of those, applications were reviewed and 7 data partners were chosen. In December, we started the onboarding of data partners, so that was the work package 1. And this month, we're kind of really kicking off the first of the 2 studies, which is around antibiotics that I'll talk about in more detail later. And then next month, we'll be kicking off the high-cost medicine study, which will be our second study. And then in March, we're planning to hold an in-person study-a-thon to wrap up these studies and get everything done and evidence disseminated by June of 2025. So quite an ambitious timeline, I think everybody will see. So in terms of the first part in getting to this data network, so as I said, there was an open call for data partners, and the proposals submitted were reviewed by a panel. So this included people from MHRA, from NICE, from UKHSA, NHS England, HDR UK, and also the Use My Data, the patient movement. And so this made sure that we were kind of onboarding the right data partners to answer relevant research questions for all of these different stakeholders. There were 7 data partners that were chosen. So we have Barts Health, CPRD, the Data Lock from Edinburgh, Great Ormond Street Hospitals, Lancashire Teaching Hospitals, Leeds Teaching Hospitals, and then University College London Hospital. All of these data partners had already mapped to OMOP, so they'd already done this huge amount of work to get to that point. Part of the application was to show that they'd mapped to OMOP and that they were ready, or that they'd already even done research with that data. So this really is what makes our timelines possible, is that they've really gone through all that hard work that we saw in the previous presentation. As part of the onboarding phase, we're doing it in 2 parts. So the first part is around checking the infrastructure, that it's ready for research. So this is things like checking that they're using a supported database management system that's supported by Odyssey tools, the ability to install R packages and connect to the database, and kind of sanity checks that the data they've mapped actually fully conforms to the OMOP Common Data Model format. So we have all the expected tables, we have the fields with the right types and so on. This is just kind of making sure all the basics are ready to go in terms of doing any research with a data partner. Then the second part of the onboarding is data characterization. So in this part, we're really trying to understand a bit better what data people have. So as part of the applications, obviously, we got people to fill in questionnaires and tell us a bit about the data they had available. But in this part of the onboarding, we're doing a more data-driven characterization. So we'll see things like the number of patients in the database, the observation periods that are captured in terms of the number of observation periods per person, their average duration, the number of records in different clinical tables and for which concepts, and also where there's missing data and so on. And all of this is kind of going to be helpful to inform the research studies that we're going to be performing. And also, just by the fact that people are able to run all of this data characterization really means that probably 95% of the analytics that we could perform is going to work well. So once all the data partners are onboarded, we're planning 2 pilot studies. The first is focused on antibiotics. So just a little bit of background, we have the WHO aware classification of antibiotics that probably will be familiar to many people, where we've got 3 groups, access, watch and reserve, related to antimicrobial resistance. So in the 2023 version of the aware classification, there were 257 antibiotics listed, and 141 of those were actually on the watch list. So that's kind of the motivation for the study, and more specifically, the study is going to be describing trends in the use of commonly used antibiotics associated with antimicrobial resistance. So really focusing on those antibiotics on the watch list. And then the objectives of the study will be to estimate the number of new users over time. And then the second part will be kind of describing the characteristics of people taking them, and summarize duration, route, and dose, so kind of a drug utilization study. So we've already shared the study protocol with data partners so that where they need it, they can get their relevant ethical approvals. We're currently working on the study code. We're fortunate in that we can leverage many of the existing tools that we ourselves at Oxford have helped develop or already exist within the wider Odyssey ecosystem. But just to mention, we have a patient profiles package and cohort characteristics package that are going to help create cohorts and describe patient characteristics. We then have the incidence prevalence package that we'll use to estimate incidence rates over time. And then we've got a drug utilization package that will help us do that drug utilization part of the analysis in terms of describing dose and duration and these kind of things. So that's the first study. The second study has a different focus, and it's on high-cost medicines. So to motivate this one, we've got the NHS England high-cost drugs commissioning list that people may be familiar with. This is a huge Excel spreadsheet with over 1,000 drugs that are of high cost, and these vary from being quite frequently used to very rarely used, and they also vary in terms of indications. So some of the most common indications for these expensive drugs are HIV, lung cancer, multiple myeloma, breast cancer, multiple sclerosis, and yeah, there's a huge list of potential drugs from that list that we could study. Where we are with that at the moment is we're working on feasibility code to identify which of the drugs are actually seen in our network, and that will kind of help inform the protocol development that we're doing at the same time. And in general, like the planned study will be to describe the utilization of these costly medicines in terms of incidence and prevalence of their use, and then do a deeper dive on the characteristics of the patients receiving them in terms of their characteristics at time of initiation, and then also looking at follow-up in terms of treatment adherence and initial and cumulative dose. So that's where we are with the 2 studies. And then given that we've got 6 months left of the pilot phase, it's going to be a busy 6 months. What we'll be doing is completing the data partner onboarding. All of the data partners have already passed these technical checks, I believe, and now we're in the process of finalizing the characterization code for the databases. We'll then run the studies to hopefully demonstrate the value of the network and have this study-a-thon that I mentioned, where hopefully data partners will have already run the studies, and it'll be about coming together to interpret the results and maybe plan the dissemination of the research, but also if there's any kind of tweaks to the analysis and things like that that are needed, we can do them during that week. And then as well, over these next 6 months, we'll be developing a sustainability plan to try and ensure the longevity of this network beyond this pilot phase. So that's a very quick, high-level overview of what's going on at the moment in the network. Just to say particular thanks to the HDR UK team, all the University of Oxford colleagues that are working on this, and especially the data partners who have been extremely responsive, running things, helping getting code running, which has been great. So thanks, and I'm not sure if we're taking questions now or also at the end.
At the end, if possible, can you say it to the end as well?
Yeah, no problem.
Awesome. Thank you so much. I think that's a fantastic update on the activity, and thank you for connecting to there. I just realized that you're on holidays, so I'm sure your line manager is not going to be very happy that you are working today. Okay, I think I'm going to ask Esmond to go next. We are perfectly on time with the agenda. We were due to start your presentation at 11:40, and we have 20 minutes for you, Esmond, when you're ready to share your screen, please.
Thank you. Thanks. There we go. Can everyone see slides?
Yes, very well.
Fantastic. Okay. I've pasted a link in the chat for everyone. Thank you for letting me present today. So I'm Esmond. I work at the University of Nottingham, and we're going to look at the Carrot Mapper tool today. Brief bit of introduction to ourselves here at Nottingham, a bit of background and context, the tool itself, what it does. I'm hoping to do a live demo, fingers crossed, and then and then look at a workshop I ran at the end of November, just a brief summary of that, and then some outcomes at the end. So who are we? I work for the Centre for Health Informatics at Nottingham. Phil leads the group. We've got Graziella and Tim there, associate professors. So Graziella does a lot of work with AI. Tim does a lot of work around federated systems, especially with Elixir. I'm a data engineer, standards engineer, background in engineering, aerospace, defence and space. I'm an ontologist and co-wrote an ISO standard and recently published UK COVID serology minimum data standard as well. And then we have Andy, our senior software engineer. So where does Carrot toolset, Carrot Mapper, etc. come from? Well, it all started sort of mid-2010s. Working with a tissue directory, and it came to full fruition by way of the CoConnect project, so funded right at the start of COVID, and it focused on trying to develop tools to enable fair data and fair data principles, predominantly mapping to the OMOP Common Data standard, and then how to be able to federate these data sets. So, as we know, I'm sure many of us know here very well, the problem with data, not just healthcare data, data in itself comes in multiple formats. I still remember talking to clinicians on the shop floor, as it were, on the wards, right in the middle of COVID, capturing everything as best as they could, be it on paper, be it in a spreadsheet, and just trying to get hold of data in exceptionally difficult circumstances. And as well, not just in healthcare, worldwide, things are often not very well structured, defined, or even explained. Data sets often don't have data dictionaries accompanying them, and if they do, they might not always be very well structured and defined for the associated data set with them. So trying to compare these things together is incredibly difficult, hence OMOP converting to that common data model enables us to start to compare things apples with apples by way of utilising standardised control vocabularies. So Carrot Mapper itself, so it is free to use, it is open source. The focus is converting source data to the OMOP Common Data Model representation. It is currently being developed. We have resource for that. We are working hard to ever improve it. We put a lot of work into enabling a really welcoming graphical user interface. We're ever improving, and we're open to yourselves and the community to further develop this. Like I say, it's open source. So if you feel there's something, if you feel it's useful and you would like to see something, then please talk to us. We hold a monthly meeting around Carrot where we give demos, updates on progress, and also listen to you, the users. So we're always interested in other people's points of view and what we can do better with the toolset. So as an overview, here's the layout of Carrot. So generally, data owners within their data environments have multiple different data systems to understand and utilize. Part of the beauty of Carrot Mapper is it sits outside of these. It sits within the University of Nottingham's secure Azure infrastructure. You need a login to access it. That login is controlled, and you can stipulate who can see what, where. And what we ask people to do is to export their data that is ingested into Carrot, and then it outputs a set of JSON rules. So focusing on that first phase, we asked data owners to prepare a view of their data, to pseudonymize it and or anonymize it, so removing identifiers, pseudo-identifiers such as postcodes and such like. We ourselves, as we map the data, we are only interested in the metadata, not row-level data. To us, it's not useful. So that view of data, we asked the data owners to do this. We asked them to utilize the Odyssey statistical profiling tool called White Rabbit that runs over that extracted, anonymized, pseudonymized view of the data and produces what we call metadata output. So a scan report, it is literally a spreadsheet of counts of values within a range of values and the metadata headers as well. So that anonymized, pseudonymized export of a scan report is ingested into Carrot Mapper, and then you can start to actually map the source data over to the OMOP Common Data Model utilizing OMOP concept IDs. Part of the beauty of Carrot is it takes away the need for explicit knowledge of SQL. So it tries to save time, tries to better enable the mapping of quicker mapping of data to the OMOP Common Data Model, and you can also map collaboratively in the environment. So let's see if I can swap over to a live demo. Okay, can everyone see? I'm hoping so. So this is Carrot. This is our landing page. So I've put the link in the chat. We have views, so projects, data sets, scan reports. You can upload a scan report. Additionally, link to documentation. So we have the documentation here, for example, so you can look through some of these things here. We're currently updating that. And additionally, there's a GitHub page as well. Again, it's open source, it's free. Please have a look. So, Carrot Mapper projects. So we have high-level view of projects here. Those within themselves have data sets. So we can have a number of data sets assigned to a given project. And then we have scan reports here. So you can see a number of scan reports that have been ingested to the system, ready for mapping. Additionally, we have an upload ability for scan reports. Literally name a scan report. You choose a data partner, whomever it be, whatever it is. Yeah, there we go, NHS Digital. You choose a data set to upload to. Public here, that means in this context, that is for anyone, any controlled user that can log into the system. So restricted, you can state who can see what and who the editors are. So you can really start to define who can do what where. You then choose your ability to upload a file. You can then add a data dictionary as well. So there's the ability to start to tie two different bits of information together for the process of mapping. So if we take a data set, I'm literally going to show you here. So the Panther data set, this was a COVID data set collected at Nottingham University Hospitals right at the start of the COVID pandemic. So by clicking it here, we can see data partner, who's been doing it, the date, current date, archive. You have the ability to archive scan reports, such like. So we can see here we've some provenance information around this. And if I click on this, we can see a number of tables here. So, for example, if I click on the questionnaire, we can see all the different metadata attributes within it. And we can see here, inside here, we can see the range of values for headache that were recorded. And yes, people have recorded things with Y, and yes, but this context around this, it was right in the middle of COVID. So I'm sure we can all understand you just want to get hold of the data. So we can see here, we have the OMOP concept ID here for headache mapped to that source metadata item of headache with a positive answer. So if I can literally just remove that, paste it in, and re-add it with, there we go, it works in a live environment, fantastic. You can see that that has literally just mapped that source metadata value for headache to the OMOP concept ID. And you can map at a value level within that, or you can map at a higher level for the values associated for a given metadata item. It depends what the data type is. It's really useful for integers and real values and such like. So part of the things around this, we have the ability to output rules, review rules, and downloads. So you can look at the rules, you can study, look what's been done. Again, this could be done collaboratively, so you could start to see what people have been working on for a given data set or project. You can review the rules again and look through from source to target, what's been mapped, how it's been mapped. We have a diagram and the ability to request the download, and here we have the output. We've have the ability to output in JSON, but also CSV as well. Additionally, you can set your progress for the mapping, so pending all the way through to mapping complete and or locked. So that's in essence what Carrot Mapper does. And here's JSON rules output. And we can see here for muscle pain, it's been mapped to condition occurrence. So part of the beauty of Current Mapper is you don't have to stipulate what goes where relative to the table in the OMOP Common Data Model. The tool will understand that you've chosen this OMOP concept ID, and it will look it up in the vocabulary and create the rule set underneath. And then obviously you have the ability to export that in JSON and CSV files. Okay, so that concludes the live demo bit. It worked. So I'm just going to go back to some slides. Something we've been working hard on is trying to reuse rules. It's all very well trying to save time and effort by way of a graphical user interface, trying to simplify the mapping process so it opens it up to a wider range of people. But we now have we've had the ability for some time to reuse rules. So as you can see here, we've got a BMI for a data set. We can see the rule is in green with an R. So the system, once you've uploaded a scan report, the system has reused a previous rule and mapped it. And then additionally, we have the ability to map against the OMOP. So all the different vocabularies that you can download from Odyssey, these exist within the tool and are updated currently twice a year as per the Odyssey schedule. And this utilizes the data dictionary, so you can, with your scan report, you can upload an associated data dictionary, as I showed you, and you can stipulate the vocabulary that you've been using, so potentially ICD-10 or OPCS4, and the tool will then look against the vocabularies from Odyssey and map accordingly. And we have this lilac color and V in brackets showing that it was mapped against the vocabulary. So what does Carrot support at the moment for the Common Data Model? So we have 7 tables: the person table, condition occurrence, drug exposure, procedure occurrence, measurement and observation, and specimen. We've been working hard on the death table, is currently in testing, and we're looking to release that very, very soon. Currently the testing that I've been doing, it looks good. So it will be great to be able to support death data with the tool, hopefully soon. So that's pretty much the Carrot Mapper. I myself, I'm interested in data standards and ontologies and such like. I spent half of my life involved in these sorts of things, and ran a workshop at the end of November last year, just as the Christmas market had been put up outside of the council house right in the centre of Nottingham. So it was entitled How to Be Fair with Data Standards, theme quantifying the risk when we convert data to a new standard, predominantly focusing on OMOP. And we had 55 fantastic attendees. So thank you for your time and effort if you're on the call. It was a pleasure to have you at Nottingham, and also thanks for your contributions. It was a great 2-day event. We had 8 tables. I split everyone up into 8 tables. We had 2 themes. One was looking at OMOP mapping quality metrics, the other data provenance. These aspects need to be looked at with OMOP, I feel. And I posed a question to start people talking around these things. All OMOP data sets are unreliable. Now that's really trying to get to people think, once you convert your data to OMOP, is it still relevant 5 years later? Is it that monolithic mapping? Is it still precise? Additionally, how can you understand, is it still precise? Aspects around data provenance, who did what, where, when, how, with what. And then additionally, how do you map to the common data model? What vocabulary do you use? Quite often, different people map in different ways. I myself work with a colleague here at Nottingham. We've mapped the same data set and we've ended up with different results. So it's trying to understand how can you measure and understand the precision of the choice of OMOP concept IDs, but also are they correct for a given context. So day one focused on the current as is, what's happening at the moment, and then day two move towards what can we do in the future. So currently I'm working on the outputs of that, looking to publish that, and we're going to see if we can start to form a community of interest or practice around this. I think it's it's a very useful thing. It can support everyone. It can better enable the uptake of OMOP internationally. And we're looking to hold a summer event around this. So we'll see how we progress with that. So in summary, Carrot, it's a free open source tool. We welcome your input. Please say hello. I'm very happy to show people the tool in depth. So a bit of training, very happy to help with that. We spend a lot of time on the graphical user interface, trying to save people time, make it easy to use, and it outputs JSON files. So we're trying to ever support those fair principles for healthcare data. So many thanks for your time and listening. And Danny, thank you. Over to you.
Thank you so much. That was a fantastic presentation as well, and very well kept to time. Really, really interesting. I think there's a lot of questions for you and the developers in the chat. I see that Phil is already taking some of them, but hopefully we have some time for discussion later.
Of course.
Thank you so much. So
thank you.
I think our last speaker is already here. Queen, are you around and available to share your screen?
Yes,
and
I am. Can you hear me
awesome.
all right?
Yeah, very good. We don't
I've had
see
endless
you,
microphone
there we go.
problems. Is that all right?
Okay. Yeah, now we
Great.
hear you and we see you as well. So if you can try and
Perfect.
share your screen, that would be fantastic.
I'm sorry, okay.
Yeah, very good.
Perfect. Right. So, hi everyone, I'm Quinn Ashcroft. I work for Lancashire Teaching Hospitals and the Lancashire and South Cumbria Secure Data Environment Programme. I'm going to be talking a little bit about how we're using our OMOP model, not just for research, but for some of our operational data as well, so a little bit outside of the normal day-to-day uses. Start with introducing the team. There's a lovely picture of me that I'm forced to use by Vishnu at the Odyssey conference, actually. I work as a data scientist and analytics engineer. I'm also a PhD student at Lancaster University. The team's in the middle. There's only 3 of us who work on the OMOP project, myself, Tim, and Vishnu. The rest of us all make up the SDE programme. And as a region, our OMOP data covers Lancashire Teaching Hospitals, which is our major trauma centre. It's 2 sites and it's quite digitally mature. And we started converting data to the OMOP Common Data Model for that trust in, I think it was around March 2022. And we were fully, March 23 it would have been, and we were fully certified as part of one of the Eden calls in June of 2024. We've used it now for a couple of research projects, quite a lot of work internally, so it's really getting traction in the organisation. And then we make up 1/5 of Lancashire and South Cumbria ICB as well, who are part of our SDE programme. So for the actual sepsis work, which I'm going to be talking about today, so a little bit of background about for people who aren't familiar with sepsis. So it's an infection and it's really quite serious, particularly it's one of the most serious and time-sensitive conditions for treatment in hospital. So there's some nice guidance that's issued around it about how patients with suspected or confirmed sepsis should be managed and what times they should have their antibiotics, clinical reviews, etc. done. So part of the recommended treatment plan is that there's certain blood tests carried out, that patients are put on certain antibiotics within an hour or 3 hours, depending on certain parameters, and that there's a senior clinical review, a reviewer referral as soon as possible, and then clinical judgment within the team to escalate as appropriate. So that is quite an established part of our trust. Sepsis has been around for a long time. The monitoring of it has equally been around for a while, but however, it's very time consuming. So at the moment, we have a sepsis nurse. She will, as part of their team, they manually monitor the patients. So they'll have them at MRN, patient level records. And they do that by going into each and every record for all of the areas. We're a hospital trust, we have multiple systems. So they could be going in up to 3 or 4 different systems to check what the parameters were. Was the actual treatment done in an appropriate timescale? Clinical time is incredibly valuable as it is. If it takes a couple of minutes per patient and there's 10, you look at an hour to an hour and a half a day of manual reviewing of a record. So the objective for this was to create an automated process that consolidates all of that data into a single view, which will then free up the clinical time for the nurses to be treating patients in person and not just retrospectively auditing treatments that patients have received. So the solution for that was to build an automated monitoring system, so that would ensure the timely interventions by tracking the at-risk patients and making sure things are being met, and streamline the processes and reduce that manual workload. So part of that would be, say if you were looking for yesterday, you would see a bottleneck potentially for drugs as an example. You could identify that now instead of a week or 2 later. So it's a much more up-to-date position and interventions if necessary. So the challenges that came from that, unsurprisingly, were quite numerous. The key challenges are the lack of that centralised system. So this is pre-OMOP, I should probably make that clear. A lack of a centralised system for our data. Information for a lot of this was stored across separate systems without that unique identifier. Some was NHS, some was medical records. We have a patient ID, all different. And it's making sure that you obviously match them correctly, depending on how numbers are entered onto the system. Measuring the potential for a patient to be septic also involves a lot of other different parameters. So you have your news scores to show if a patient's blood pressure, temperature, pulse, etc. is higher or lower than expected. And that's what forms the core basis of us including a patient, is if their news score is 5 and above or 7 and above, depending on, and that determines your time window. We needed prescription details, drug administration, bloods, all the patient location information. So all of that is generally stored on a separate system. So quite difficult to try and collate in one place. So querying the systems was also time consuming. So a lot of the blood results would have come from our pathology system, which is, it's not a reporting server, it's a live operational service. It's not set up to be good at retrieving data from, so that could be about 45 minutes per query, I think, for 2 or 3 of them. And drug information, we use electronic prescribing, which is from EPMA. It's not part of our core EPR. There is a link between them, but the data that comes out isn't necessarily what's seen on the front screen, and like making sure prescriptions were linked to all of the records that came out. It wasn't in place before we had our OMOP instance up and running. So the process and the pipeline for creating this automated dashboard. So we started working with quite a wide multidisciplinary team. It included our medical director, our critical care outreach team, sepsis nurses, myself, Tim for the technical side, and also our EPR analyst as well. So quite a wide team to try and make this happen. And then this was before we started converting to OMOP. So at this point, we've now started converting to OMOP and started linking those systems together. So our OMOP instance is refreshed daily using incremental loading. So I spoke a little bit in the introduction is that we wanted to have an OMOP instance that wasn't just research, because it's incredibly resource intensive making and creating that OMOP CDM. So it took us about 6 months to get the first set up and running, and 15 months for a fully certified instance. That's a lot of work and resource when if you're just going to use it, not just, but only use it for research and only refresh it every few months. So by us having a daily refresh, we can use it for operational use and then research, which then leads into how we have our instance set up. So we have our source to bronze layer. We follow the medallion architecture. So all of our data comes out, goes through our ETL pipeline, stops at bronze. That has almost pretty much close to source, but with the concept IDs attached to it as well. So it's in the OMOP like convention, but not necessarily the standard, because we haven't applied any data quality. It's literally as close to source as possible. That goes through a set of tests, an application of some of the OMOP CDM constraints to make it OMOP compliant. However, we leave in the operational layer, because it's for it's operational use. We don't take out our patient opt-outs at this point, so our data opt-outs remain in. We wouldn't necessarily take out all of the dodgy data quality, like some dates that might be incorrectly things or things across different visits. We'd keep all that in, because the local knowledge knows how to handle that when analysing it. And then to get to gold, that's when our opt-out comes out. All of our strict data quality applies to it. Optimization, and it meets the OMOP standard completely as well. So those are our 3 levels. Data for this project came from the silver one, because we needed all of our patients in there, even if they'd opted out, etc., etc. And yet we achieved this by, like I said before, incremental loading. So instance of Easter, it's up to midnight the night before. So if you went into our OMOP instance now, you'd see records up to the 8th of January 2359. So really useful for this sort of data. And how we structured it for this project, what we did is we identified concept IDs. So we focused firstly on retrieving blood results better and our drug results. So we created concept sets for both, and took them out from the silver layer using a link server to link back to our original sepsis base. We also have news scores in OMOP. We have all of our blood tests in OMOP, so you can see quite quickly how instead of us having to access multiple systems, we're just going to one now, and it's a lot quicker. Already, I think our query to measurement for the bloods takes a couple of seconds, whereas it used to take about an hour to get data from our pathology system. So what we ended up with, the outcome for it, is we ended up with a successful automated dashboard. Sadly I can't put any screenshots of this on. It's quite patient level heavy, so you'll have to imagine a very nice dashboard with some graphs. I did try and get some, didn't look too good, so I thought I'd best leave it out. We ended up with a successful automated dashboard. It refreshes every morning for our clinical team. They access it through our apps anyway as it is, so they're quite familiar with where it goes. We have a clinical documentation app, it sits in there. And it successfully integrated OMOP data into a monitoring process, which we'd never used sort of that data for before. It feeds, so it provides that up-to-date patient data. So what our clinicians can do every morning is they can sit down, look at the compliance within a click to a button. They have their list for patients for whatever time period they want. And I know they're still using it as well, which is always nice, because I had a call from the sepsis nurse yesterday asking about some questions for it. So it's something that they find really helpful. She now uses that list exclusively to help identify patients for her to then go follow up clinically. So it is a guide in that sense. It doesn't replace anything, because it is data, whereas she still needs to her clinical judgment against it, but it saves that time of manual trawling through notes. It ensures all that relevant data is very accessible as well. So whereas I said before, you had to go across all the different multiple systems, it's on one line per patient trigger. You get all your blood, your IV fluids, any escalation up to critical care, indication for prescriptions, everything is in one place. With our EPR as well, say if you went into their records, you might have to find the right prescription for the right timestamp. This will give you it now, the first prescription for that patient. So it's all set out in one line for them. They can take it into Excel if they want and then filter that way. There's quite a lot of options for them. A year's worth of data identified around 4,700 patients who met the specified parameters, averaging 13 patients a day. And then using the OMOP data allows identification of those relevant results really, really quickly. And overall, it's significantly streamlined the process of monitoring that compliance with our NICE sepsis management guidelines. It removes all that need for time-consuming reviews, and it overcame the limitations of our traditional data sources, which were quite disparate in terms of patient IDs and how they were stored and accessed. And then that use of OMOP layers, including that operational silver layer, allowed for the broader data utilisation across that the scope of our data, and adds to us not just using it for research, supporting that operational intelligence and service evaluation. It gives us like a good unified view of healthcare data. Hopefully it really supports the clinical teams, and we're hoping for our future work to focus on making OMOP that single source of sepsis monitoring, because we use a base query and add OMOP data to it. We'd like to move it fully to OMOP like we've done with our chronic kidney disease monitoring work. That's now fully OMOP, so trying to move everything into one single place. And if it is successful, hopefully when it's successful, it's a model that could be shared across other NHS providers if they wanted to do the same. Particularly I think that might be useful for things like sequin data, any NICE monitoring, which are pretty standardised across all trusts. You could then reduce that workload and hopefully share across similar centres. That's everything. I've a little.
So I was on a bit of a dim moment there. Of course you did.
No, I did it. We did it the first time, and it was Ed who went, "Oh no, they're not standard." It was back in the first hackathon, I think, last November, and then I found that maps too. So it all came from that, really.
Brilliant. Thank you. Thank you.
Right. I don't think there's any other questions in the chat that haven't been answered by any of the speakers. So we might be in a position to give you 5 minutes back of your time for once. This doesn't happen very often. Just to remind you once more before we close, the date for the next meeting, the next OMOP Special Interest Group meeting is 6th of May, 1 p.m. So please add that to your diaries if you joined late and didn't see this. And the date for the next Odyssey UK meeting, in-person meeting, will be on the 26th of September. And we will, of course, give you more information about all this later on. Thank you so much to all the presenters. Thanks, Alex, Waya, and everyone who helped organize this meeting. And yeah, thank you everyone who attended. We had up to 65 people, which is really impressive. And yeah, it was a really enjoyable time. Thank you, everyone.
Thank you. Bye.
Thank you.
Thanks, everyone.